Bismillahirrahmanirrahim. Our graduation research is the shape and size of maxilla to mandible in the class 2 malocclusion. The introduction: malocclusion nowadays is one of the most frequent oral cavity anomalies. It's defined as the abnormal occlusion in which teeth are not in a normal position in relation to the adjacent teeth in the same jaw or to the opposing teeth when the jaw are closed. Class 2 malocclusion is condition when the mandibular مثل ما بين بصورة يكون mandibular first molar distal to the maxillary first molar. Etiology of the class 2 malocclusion varies between the skeletal, soft tissue, dental factor, and habits. Morphological characteristics of the size and shape of dental arch and the arrangement of the dentition differ between the race, culture, and region. The arch form should be determined in the relation with each patient's pre-treatment dental model and especially in the relation with each patient's ethnic group in order to achieve aesthetic affection and the stable arch form outcome. And the analysis of the study model has been used for the three-dimensional evaluation in the upper and the lower jaw, اللي هي arch length, arch form dimension, and the mesodistal tooth size. Malocclusion can be diagnosed if there is a discrepancy or the surplus of the tooth material, either in the maxillary arch form or mandibular arch form. Understanding the natural dental arch form is important as the average values of the anatomical shape and size of arch are useful for prosthetic restoration and orthodontic treatment. For this reason, many studies have addressed the shape size of dental arch. الأكلوجن تعريفه هو is the manner in which the lower and the upper teeth intercuspate between each other in all mandibular position or movement, classified by the experts into the three types. The three terminal occlusion عندنا هو normal occlusion, ideal occlusion, and malocclusion. McDonald's and the airlines عرفنا ideal occlusion على إنه as a condition when the maxilla and the mandible have their skeletal bases of the correct size اللي يكون عندها relative ما بين upper arch and the lower arch and the teeth are in the correct relation and the three septal planes at rest. بينما هوستن عرفنا normal occlusion على إنه as the occlusion within the aesthetic definition of the ideal and which caused no functional or aesthetic problems. The malocclusion is a misalignment or incorrect relation between the teeth of the two dental arch when they approach each other as the jaw closes and usually caused by a problem with the shape or size of the jaw or teeth. Common cause is having يا إما يكون too much or too little room in the jaw. إذا كان children عند الجو ما راح يكون small فالteeth راح يصير بها crowding or crooking. If there is too much space in the jaw, the teeth may drift out of the place. Causes of the malocclusion: the most often hereditary عادة غالبا هو راح يكون وراثي وراح ينتقل عبر families. It may be caused by the difference between the size of the upper and the lower arch. يعني مثلا أحد الأرش راح يكون أكبر من الثاني، يعني مثلا الأبر أكبر من اللور أو بالعكس. Or between the jaw and the tooth size، يعني يكون الجو مثلا small and the tooth تكون normal size، أو راح يكون very large the jaw أو التooth راح تكون normal. It causes tooth overcrowding or abnormal bite pattern. The shape of the jaw or birth defects such as the cleft lip and palate may also be reasons for the malocclusion. Other causes: childhood habits such as the thumb sucking, tongue thrusting, behaviors used beyond age 3, and prolonged use of the bottle. اللي عندنا مثل ما مبين بالصورة إنه راح يصير عندنا overbite. الإكسترا teeth, loose teeth, impacted teeth إذا صار عندنا impacted upper canine or abnormally shaped teeth. Opening denture, opening dental filling, crowns, dental appliance, retainer or braces. misalignment of the jaw fracture after the severe injury. إنه من راح يصير عندنا fracture بالماندبل مثل ما واضح بالصورة إنه راح يصير عندنا shifting ب tumor of the mouth and the jaw. أيضا مثل ما واضح بالصورة إنه عندنا tumor بالماندبل بيقدر صار عندنا shifting laterally. Abnormal shape or impacted teeth, poor dental care that result in the improperly fitting dental filling, crowns or braces. حتى راح تكون عندنا high spot أيضا هي راح تسبب لنا malocclusion، فيجب أن نتخلص من عندها بسرعة ونتفادى هذا malocclusion اللي ممكن يصير. airway obstruction, mouth breathing caused by the allergies or by enlarged adenoid or tonsil. اللي راح يصير عندنا إنه البيشنت راح يكون يتنفس من فمه، فراح يصير عندنا open bite لأن البوزيشن مال التم راح يكون forward. There are the different categories of the malocclusion. عندنا the class 1 malocclusion is the most common. The bite is normal, but the upper teeth slightly overlap the lower teeth. The class 2 malocclusion could the retrognathopharism or overbite occur when the upper jaw and the teeth severely overlap the bottom jaw and teeth. The distal relationship mandible to the maxilla، قلنا انه هاي الريليشنشيب راح تبين من المانديبل من الفيرست مولر الابر اند لور. الميجر بوكال كاس من الماكسيلاري فيرست مولر راح يكون ميجيال تو ذا بوكال جروب اور ذا مانديبولار فيرست مولر. عندنا نوعين من الكلاس 2 مالوكلوجن، ديفيجن 1 ديفيجن 2. ديفيجن 1 راح يكون ماكسيلاري انسايزر ليبيالي، وديفيجن 2 راح يكون ماكسيلاري سنترال انسايزر، يكون اما نورمال او راح يكون سلايتلي لينجوالي. الماكسيلار لاترال انسايزر يكون ليبيالي. وعندنا ايضا نوع السب ديفيجن when the dislocation occurs on the one side. sub division راح يكون يعني الديسلوكيشن يصير على one side فقط، يعني مثل الموضح بالصورة انه cross bite. Etiology of the class 2 malocclusion: heredity, development defect مثل cleft lip and palate, trauma, physical agent, habit, disease and malnutrition. The clinical features of the class 2 division 1 extra oral features: البروفايمات راح يكون convex، المنزوليبيال sulcus يكون deep، upper lip short hypotonic، اللبس يكون component or incomponent، lip trap. الانترا-oral features class 2 يعني molar relation: broccline maxillary incisor or maxillary anterior increase overjet، flaring and spaced dentition. الجو راح يكون V shape with deep curve of speed. Abnormal muscle activities: abnormal vaccinator activity, lower position of tongue which predisposing of the posterior crossbite, hyperactive mentalis muscle. Clinical features of the class 2 division 2 profile راح يكون straight or convex، reduce the lower facial height، هالمنطقة راح تكون صغيرة، mentolabial sulcus تكون normal or deep، والpath of closures يكون backward. Intraoral features: الكلاس 2 molar relationship: retrocline upper central incisor بس procline عندنا lateral incisor، upper lateral incisor. overjet decrease deep bite، arch راح يكون U shape and the deep curve of speed. The treatment of the class 2 malocclusion بالنسبة للgrowing patient و non-growing patient يكون إما skeletal أو dental. الskeletal بالنسبة للgrowing patient يكون orthopedic هي functional appliance، و non-growing patient الskeletal راح يكون surgical treatment. لكن الdental بالنسبة للgrowing و non-growing راح يكون هي fixed orthodontic treatments.
بسم الله الرحمن الرحيم. My name is Shams Bayan. Now I will complete my part. Class 3 malocclusion definition: according to British Standards Incisor Classification, in Class 3 malocclusion, the lower incisor edges lie anterior to the cingulum plateau of the upper incisor. The overjet is reduced or reversed. While according to the Engels classification, in Class 3, the mediobuccal cusp of the lower first molar occludes medial to the Class 1 position. Class 1 position in which the mediobuccal cusp of the upper first molar occlude into the mediobuccal groove of the lower first molar. The etiology of Class 3: first, long mandible, forward placement of the glenoid fossa, positioning the mandible more anteriorly. Third, short and or retrognathic maxilla as seen in this figure, and short anterior cranial pace. Normal growth and development of the arch form and width. First of all, arch dimensions change with growth. It is therefore necessary to distinguish changes induced by appliance therapy from those that occur from natural growth. The average changes achieved in a sample reported by Moyers et al. 1976 included that the changes in width vary between males and females. The male have more growth in the upper than lower arch. This growth occurs mainly between the ages of 7 and 12 years of age and is approximately 2 mm in the lower arch and 3 mm in the upper arch. After the age of 12, the growth in the arch width is seen only in male, while females show constriction. Changes in arch width may not be accompanied by changes in arch length. There is a tendency toward a decrease in arch depth in the third and fourth decade of life. Studies on relapse in arch form after orthodontic treatments. Arch form changes: 65 of cases had a change in arch form and 65% returned to their pre-treatment shape. It means total relapse. Arch width changes: according to growth, age, and amount. Growth: there is no evidence that appliances can stimulate growth beyond that which would normally occur. Age: it seems logical to consider increasing arch size at a young age so that skeletal, dentoalveolar, and muscular adaptation can occur before that, the eruption of the permanent dentition. Amount: approximately 3 mm stable upper molar expansion can be achieved and stable. Approximately 1 mm stable lower molar expansion can be achieved and stable. There are exceptional local factors for this relapse. Buccally or lingually displaced canine can be repositioned to their normal position without risking the stability of arch width changes. Deep bite cases, such as Class 2 Division 2 cases in which lower canines have inclined lingually in response to the palatal contour of the upper canines. Cases where rapid maxillary expansion is indicated in the upper arch and this expansion is maintained post-treatment but to very limited extents. Implications of the size and shape of dental arch. The size and shape of the dental arch have considerable implication for orthodontic diagnosis and treatment planning. These have an effect on the space availability, stability of dentition, dental aesthetic, health status of the periodontal ligament, treatment planning, space available, treatment mechanics, bracket prescription, selection of orthodontic wires, and stability and prognosis. Factors determining the arch forms. Ethnicity, with underlying genetic basis that determine the basal bone which accommodate teeth. As example, in Caucasian population, 45% have ovoid, 45% tapered, and 10% square. Also, the type of malocclusion, like in class 3, the majority are square form. Musculature, which adapts the above position to the new one. Environmental factors like in standing teeth, habits, and crowding. Orthodontic treatments. Basic arch forms. Chuk in 1932 classified the arch forms into 3 basic arch types. Square arch forms. For patients with broad arches, this is used. The square form is useful in maintaining expansion in upper arch after rapid expansion. When superimposed, the 3 shapes vary mainly in intercanine and interfaced premolar width, giving a range of approximately 6 mm in this area. Ovoid arch forms. Being the most preferred arch form, it results in minimal post-treatment relapse. It shows a greater intercuspal distance than tapered form. Tapered arch form, it has the narrowest intercanine width and is useful early in the treatment for patients with narrow tapered arch forms, especially in cases with gingival recession in the canine and premolar regions. There is very important note when comparing the arch forms, square, tapered, and ovoid according to different classes. The commensurate arch form in class 1 was the ovoid followed by tapered. However, in class 2 and class 3 subject, the commensurate arches were tapered. These findings strongly suggested that ovoid form should be considered when dealing with class 1 cases and tapered form when class 2 and class 3 cases. Dental and alveolar arch widths in normal occlusion, class 2 division 1 and class 2 division 2. Findings indicate that maxillary interpremolar width, maxillary canine, premolar and molar alveolar widths, and mandibular premolar and molar alveolar widths were significantly narrower in subject with the class 2 division 1 malocclusion than in the normal occlusion sample. The maxillary interpremolar width, canine and premolar alveolar widths, and all mandibular alveolar widths were significantly narrower in a class 2 division 2 group than in the normal occlusion sample. The mandibular intercanine and interpremolar widths were narrower and the maxillary intermolar width measurement was larger in the class 2 division 2 subjects when compared with the class 2 division 1 subjects. Also, maxillary molar teeth in subjects with the class 2 division 1 malocclusion tend to incline to the buccal to compensate the insufficient alveolar base. For that reason, rapid maxillary expansion rather than slow expansion may be considered before or during the treatment of class 2 division 1 patients. Now we complete our research, and thank you.